All right, I think my 3 seconds are up. So welcome everyone. It's Rohan Jayaraja over here. I'm so sorry I missed the last grand rounds. I was actually in India, which was really amazing, but I was too busy with relaxing to join, to be frank. This is a wonderful group of people that we've got together. We're really honored to have Dr. Zureikat moderate this. As you all know, he's a world-renowned pancreatic robotics surgeon at UPMC, and frankly is just, apart from being so fantastic, he always does things for the right reasons, Amer, and that's what I love about Amer, is that he does things for the good of surgery and moving it forward, and that's just such a great characteristic. And so I was really thrilled when he accepted the invitation to moderate this. I'm so thank you, Aleksandr Kalabin, for choosing the topic of robotics in HPB surgery. I think just for those of you that don't know Alec, he's a fantastic human being trained in New York and is at Missouri right now with Kimchi, doing a Advanced GI Fellowship, which is a lot of foregut and HPB. And then he's going to be joining John Martini and David Inetti for an additional 2 years of training in HPB. And so he's the perfect person to talk about this topic. So without further ado, Dr. Zureikat, let me hand over to you.
Rohan, thank you so much for this kind invite and the kind words. Congratulations to you on putting together this consistently excellent seminar. So it really speaks volumes when such an esteemed group of people are actually attending consistently your talk. So really appreciate it, and thank you again for the opportunity. So I just a bit of background. The University of Pittsburgh started its program in 2008. So we have about 14 years worth of robotic HPB experience. I'm really happy to be sharing some of that with you, including the the tricks and the pitfalls and issues with the program, and how it's really not about doing cases, but about building a program. That's really HPB surgery, not cases, but programs. Looking forward to Aleksandr's talk. Aleksandr is going to be giving a talk on robotic liver and robotic pancreas. And we'll stop him and ask some questions, and we'll debate some issues afterwards as well. So thank you again.
All right. Good afternoon. Thank you all for joining us today. I'm sharing my screen. Is it okay? You can see it? Awesome.
Yes. Yes.
Perfect. First of all, I would like to thank the Society for Surgery of the Alimentary Tract for the great platform, Dr. Zureikat for being a moderator. I didn't include here in the slide, but I personally would like to thank Dr. Jayaraja, who's always pushing us trainees for something better, for improvement. Today, I would like to talk a little bit about robotics and HPB surgery. As Dr. Jayaraja mentioned, this is mostly, I would say, my personal interest that I would like to be an expert in future. Quick disclosure, I don't have any conflicts to disclose. I divided my presentation, my talk today, in 4 different kind of segments. First, I would like to briefly speak about current status of HPB and robotic surgery in general. And then we're going to talk about liver surgery, robotic liver surgery, and robotic pancreatic surgery. And then we'll have some time for questions and discussion. In regards to HPB surgery, where we are currently, majority of HPB procedures are still performed using an open surgical approach nowadays. HPB surgery is considered high morbidity procedures, although over the last decades, we see a really good trend in decreasing the morbidity and improving the outcomes of the HPB procedures. A couple of reasons why HPB surgery considered a pretty morbid procedures, most likely due to the anatomical factors. HPB structures, pancreas, duodenum, they retroperitoneal structures considered pretty deep, if we can use this word. Also, intimate relationship with major vascular structures. So add to complexity of those procedures. Unfortunately, and I think this is one area of improvement regarding general surgery residency requirements. I personally believe they're pretty low. In order to graduate from a general surgery program, I think residents need five liver and 5 pancreatic cases, which is obviously not enough to have comfort doing those cases. Also, a lot of surgeries nowadays are done with minimal invasive approach, laparoscopic approach. However, laparoscopic surgery in HPB, they also have their own limitations, rigid instrumentation, 2D vision, really bad ergonomics compared to robotics, and steep learning curve. And as a kind of a major conclusion from everything that I mentioned is, unfortunately, due to the complexity of the HPB procedure, the transition to robotic is trailed behind other specialties. In general, we all aware about advantages of the minimal invasive surgery, and robotics is not a is not an exclusion from this rule. So reduced postoperative pain, reduced morbidity, decreased length of stay, improved cosmesis, of course, improved overall cost effectiveness, and a lot of authors are comparing outcomes, stating that that oncological outcomes comparing minimal invasive surgery and open surgery nowadays are about the same. On the other hand, we have robotic surgery, and again, this is something just to mention one more time: the advantages of the robotic surgery. 3D, high definition magnified field of vision, tremor filtration, motion scaling, and the wrist articulated instruments are used in robotics that recreate the 7 degrees of freedom of the human wrist. A lot of procedures could be done with great precision and accuracy, and some of the studies comparing laparoscopic and robotic approach actually concluded that a learning curve in robotics is faster compared to laparoscopic surgery. However, unfortunately, also robotic surgery has its own disadvantages. Advanced skills are needed to perform major procedures: suturing, knot tying, tissue manipulation. One of the major drawbacks cited by a lot of authors is loss of haptic feedback while performing robotic surgery. Another drawback, which is highly cited, is high costs for the procedure, mainly because of the increased operative time and increasing financial burden in relates to OR time usage. Always during the robotic surgery, we need another assistant. Most of the time it should be a pretty skilled bedside assistant. I'm not sure how other institutions are managing this issue. Some of the institutions using residents. I know some centers utilizing especially trained PAs, robotics PAs. However, during my literature review, some of the authors saying even sometimes attending could be utilized for the more complex procedures. And unfortunately, as of now, robotic surgery mostly utilized in high volume tertiary centers. Not all of the community hospitals have robots. I apologize, something happened, some technical issues. 1 second.
Alec, if you want to unshare and then share again, sometimes
Uh,
that works.
yeah.
So while you're doing that, Dr. Zureikat, do you want to comment on bedside assistance?
Yeah.
Like, how do you handle that?
So Alec, I think all these are important points, but certainly not to dissuade anyone from picking up robotic surgery. All of these can be overcome with time and experience. So I think the loss of haptic feedback is very important, but you begin to tie and sew and feel with your eyes, so to speak. Obviously, cost is always an issue, and you're probably going to be equivalent to open surgery. But if you have big changes in length of stay, you can certainly realize an improvement. And then finally, the bedside assistant. I think if it's a small wedge resection of the liver or a distal pancreatectomy, I think a resident is fine at the bedside. I think the biggest animal is really the Whipple, and for that, I would advocate having an experienced bedside assistant, even an attending, for the initial learning curve of a program. We did that for a while. We were integrating new surgeons into our staff, and in total, there were 6 of us doing robotic Whipples at one stage. And when some of those surgeons were only seeing 5 or 10 cases a year, and they wanted to jump on the bandwagon, it was not appropriate to have really that attending with a resident, even though they were expert Whipple surgeons. There's a bit of a learning curve there. So beyond that initial learning curve, which it's debatable the exact number, but you could probably say somewhere around 50 to 100, I think, is a reasonable number for robotic Whipples. I think beyond that, you could go back to a situation where it's an experienced attending, doing it with a resident. This is currently the scenario we have in Pittsburgh. I mean, obviously, we had a situation where for a period of about 6 years, there was 3 expert robotic Whipple surgeons really doing it. And with Zay and Hogue leaving us, we've integrated new staff in, and now those staff are up and running with fellows working with them at the bedside, completely independent. I mean, it's only rarely that we have to double scrub for an uncinate. The only thing I would say, though, is in a Whipple or probably in a major liver, it is good to know that you have another attending on site. I think that's one thing that we would make sure that we have, is an attending on site, because when you get into bleeding, the maneuvers that you need to perform to get out of it and convert safely or suture ligate, you just need a bedside assistant that can be facile. But certainly you can move away from all of those limitations with experience.
So just in order to let Alec get through the talk, let's keep moving, Alec, and we'll come back to some of these issues. There was a couple of questions in the chat, but we'll get there.
Yeah, thank you so much, Dr. Zureikat. A few historical aspects of the robotic surgery in general. It was first brought to market in 1997, approved by FDA in the United States in 2000. First Whipple was performed in 2001 by Giulianotti and colleagues. I think it was University of Chicago. First distal pancreatectomy in 2003, and first robotic liver resection in 2007, I think. Most widely used device nowadays, we're all aware, Da Vinci surgical system, this was a national trends, a paper regarding national trends in robotic, I think, pancreas surgery. Just to compare, just to have raw numbers, in 2010, 150 robotic pancreatic duodenectomies were done in the United States, compared to 2016, where 450 surgeries were done. This is just a picture of Da Vinci Xi robot that utilized in most of the institutions. I would like to move on and to talk about robotic liver surgery. Most of the papers describing utilization of robotic robot in a lot of different pathologies, liver pathologies, but most of the time it's used for HCC, more than 50%. The second most common is colorectal metastasis, and also benign liver diseases such as hemangioma, adenomas, and goes as a third condition. Easy dissection of the hepatic hilum, fine lymphadenectomy, biliary reconstruction, effective bleeding control, and near infrared fluorescence imaging. These are the kind of advantages of the robotic utilization in HPB surgery. In regarding to indications of the first international consensus statement on robotic liver surgery was held only in 2018, and no strict criteria were published. So there are no guidelines or no clear-cut indications in robotic liver surgery. For minimally invasive and laparoscopic surgery, actually, most of the authors will agree that resection of anterior segments 2 to 7 and solitary peripheral lesions less than 5 centimeters, these are the most common indications for minimal invasive approach in liver resection in general. However, I went over a couple of papers, and actually a couple of authors are suggesting that a robot should be more utilized in to approach posterior superior segment such as segment 1, 4A, 7, and 8, so-called incision dominant operations. This is one of the, this is a slide just to show audience the trocar placement for robotic right hepatectomy. I took it from the case series done by Dr. Giulianotti. Straight line just above the umbilicus, we can clearly see. Critical steps suggesting utilization of Gleasonian pedicle approach, extrahepatic, the 3 main steps: dissection of hepatic hilum, hepatocaval dissection is the 2nd step, and the 3rd step is transection of the liver. A couple of tools that can be used in liver transection, utilization of the low CVP, Pringle maneuver. Some authors routinely do Pringle maneuver before any transection. I think the area of controversy here is what tools could be utilized for liver transection. Some authors describing bipolar forceps and crush and cut technique. Some authors using staplers for vascular structures. I'm personally, I don't have a huge experience in robotic liver resection, but my understanding, ultrasonic aspirators, unfortunately, are not there yet in a robotic technology, and that's something probably that we can discuss later on with Dr. Zureikat. Robotic left hepatectomy, another common procedure that is done with a robot. Trocar placement is similar. Third arm sometimes can be moved to the far right. And also Gleasonian pedicle technique is utilized with dissection of the portal triad and ligation of the artery, bile duct, and portal vein. Robotic assisted segmenectomies, these are also commonly used surgeries utilizing robot. Trocar placement is usually variable depending on the segment to be resected. But other than this, steps are about the same. Dissection of the hepatic pedicle, Pringle maneuver as an adjunct could be utilized. Parenchymal transection with harmonic shears or some other devices. Most of the authors describing gentle retraction, of course, hemostasis and liver surface examination at the end of the procedure.
So can we just stop for just a second, Alec? Let me just ask Amer if you could generate some discussion around extrahepatic dissection versus, intrahepatic, sort of just cut and go type with this, Amer, and we can engage the audience. So if you want to ask.
Yeah, so I've certainly done them both ways. I don't do nearly as much liver as I do pancreas. But maybe someone from the audience.
Yeah, why don't we ask John Martini? Do you want to comment on this, John? Alec is going to be your next fellow. Do you
Sure.
want to comment on whether you like to do an extraparenchymal dissection before a transection, or whether you get everything intraparenchymally as you come through?
Yeah, I think it depends on the case, but I mean, I think the main thing for me, for robotics, and why I switched from laparoscopic liver, which I was doing up until about 2012, was really to do the extrahepatic dissection. So for me, an anatomic liver resection for me is kind of how we used to do them open. So it would be an extrahepatic, so opening the capsule, dissecting, taking your vessels outside the liver before you split the liver, and then splitting the liver with the parenchyma. And then lastly is the take the veins inside the liver. So it's a totally different approach than laparoscopy. It's as different as lap and open, I suppose. And that took many, many years to evolve into that technique.
John, do you take the short hepatics and the right hepatic vein, for example, outside?
No, the short hepatics for a few maybe halfway up, maybe 30 to 50% of the way up the cave, as much as you can see. But I almost never take the right vein outside the liver anymore, because I don't mobilize the liver, because the patients are supine. So it's a completely anterior approach. Again, the patients are just totally supine. We don't mobilize the liver at all. It's all basically right down the middle.
So, and I kind of wanted to bring up that theme, Amer. One of the things that I've noticed as we look at MIS approaches, that you look at colorectal, it's medial to lateral. You look at distal pancs, it's medial to lateral. You look at Whipple, it's straight down, at least for me, and then you go to the right. It's sort of a completely different way than we do these things open, although I always go medial on things open too now, because I've learned from robotics. But Imran, do you want to comment on that, this kind of medial technique? Colorectal surgeons have done this for a while, right?
Right. No, I think it's the matter of the exposure, because even the medial to lateral there are variants to that. Like for the left colon, you can do the IMB first, and then you can come from top down. So some of it comes down to the anatomic constraints, and it may be different from the liver, but at least when we train residents, we say you need to know more than one way of doing the same thing, because it's not, no patient reads the book and comes to the OR. So that's why you have to have more than one approach. Yet we always say you do the same way every time, so you have a standardized technique. So it is a bit of paradoxical thing, but that's just for the colon. The colon is much less forgiving than the pancreas, which is why I don't look at the pancreas whenever I come across it.
Shall we keep going, Amer?
Yeah, I think just one point I want to make about the hepatectomy, which I think John mentioned it. When I was doing them with Dave Bartlett, as we were starting up, we would also take extrahepatic inflow, outflow, but also making sure that the right hepatic vein is taken within the liver. I think if you are to run into trouble in that operation, it is trying to push hard to get the right hepatic vein stapled outside the liver. I think when we talk about HPB surgery, obviously we talk about robotics and benefit, but certainly you do want to avert a big bleed, and that's one of those pitfalls, is try to avoid it early on.
So just one last comment with regard to this. Alex Rosemurky, can you just comment, do you use a liver hanging maneuver for this rather than, sometimes robotically you can do a liver hanging? Is that something that you advocate, Alex? If you're on, or Shlomi, since you work with them? Nobody's signing on. Does anyone else use the liver hanging maneuver at all in these cases for right?
No, it's really difficult maneuver to do. I've tried it a few times and simply abandoned that.
Yeah. Okay. All right. Let's keep going, Alex. Sorry to interrupt.
Sure. Oh, no, you're always welcome. A couple of papers and some literature search in regards to major hepatectomy outcomes. So one of the first case series was published, as I said, by Dr. Giulianotti. And at that time, he looked at the outcomes of major liver resection the column on the left side. So most common indication for his procedures was malignancy. Mean operative time was 313 minutes, EBL 150, transfusion rate 22%, conversion to open was only 3.7%, overall morbidity 29.6, mortality 0, and resection margins were all negative. Another case series was published, I think this one from Europe, from Italy, about the same numbers. Most of the cases were done due to the malignancy. Mean robotic operative time was a little bit bigger, 430 minutes. Median EBL was also comparable to the previous paper that I mentioned, 250. Conversion to open 4%, and transfusion rate 44%. For minor story hepatectomy outcomes, these are the main results of also Dr. Giulianati on the left and European group on the right. As you can see, the operative time was a little bit less compared with major hepatectomies. EBL also a little better, transfusion rate lower, and mortality was 0%, and morbidity also better compared to major hepatectomy outcomes. Another paper that I want to mention and go over really briefly is actually coming from University of Pittsburgh. This is the review paper. They looked over 14 major series, 439 patients, and operative time range from 90 to 812 minutes. And as Dr. Zureikat mentioned at the beginning of this presentation, the operative time can be overcome with more experience. Same thing with EBL. You can see the huge range from 50 to 413 milliliters, and the transfusion rate from 0 to 44. And again, reduced blood loss could be overcome with more robotic experience. Another interesting fact from this paper is comparing robotic and laparoscopic cases. So basically, a major conclusion were done, and actually, in regards to length of stay, the range of length of stay was from 4 to 12 days, which was similar to laparoscopic group. Oncologic outcomes were also comparable to laparoscopic group, and costs were a little bit higher than laparoscopic surgeries, mostly due to the longer OR time. The major conclusion from this review paper that robotic and laparoscopic liver resection have comparable outcomes, and mostly and outcomes were dependent on learning curve. With more cases done robotically, the outcomes were better. Unfortunately, no randomized controlled trial are still done comparing these two approaches directly. Another meta-analysis was done in 2019 that included about 1,000 patients. What they found is robotic group had decreased intra-op blood loss by an average of almost 70 milliliters. A robotic has longer operative time, about an hour more than laparoscopic group. A higher cost with utilization of robot on a mean difference of $4,240. Other outcomes were comparable between these two groups. Just to summarize everything in regards to robotic liver resection, I'm sorry. So certainly there are some limitations. We mentioned before, I'm gonna say one more time, lack of haptic feedback with robotic approach, needs for skilled bedside assistance. Sometimes large incision could be utilized for specimen extraction, however, could be avoided. Extra time for docking, undocking. increased cost for a robotic approach, on average 13% higher than laparoscopic surgery. And a couple of things that are not, again, I would like to hear expert opinion in regards to argon coagulation utilization in robotic surgery. My understanding, not that often used for hemostasis purposes as an open surgery. And ultrasonic aspirators also, the usage is pretty limited in robotic surgery. Few
Alex, maybe just a comment here.
Sure.
I think it's hard to prove a benefit for robotic versus lap when it comes to hepatectomies in general, but mainly minor hepatectomies. I think the difference is in the ability to expand your minimally invasive kind of portfolio to posterior segments. I think that's really where the robot comes into play, the ability to get up above the dome of the liver and to do those posterior segments. Obviously, the inflow is easier robotically. You've got more control. But when it really comes down to it, I think the NISQIP data showed us this, and others have shown us this, that the robotic approach may not be beneficial over laparoscopy. Certainly both, you could argue, are beneficial compared to open. But if you want to compare them head to head for minor hepatectomies, I think there may not be a benefit other than the posterior segments, which I don't know if others agree or disagree. Obviously, the ability to avert a conversion is always important. But with a minor hepatectomy, that chance is very small. So some of the Pittsburgh data focused on left lateral segmentectomies. Those are operations that can be done laparoscopically, safely, quickly, probably less cost. So overall, I think the jury's out on lap versus robot liver. There's only a couple of benefits there that I think are worthwhile.
So let's ask for a comment. Iswanto, I don't know if you just joined and heard that discussion regarding lap versus lap versus robotic hepatectomy. Again, Amer, maybe the thing that we're most comfortable with is the thing that works best, but what do you want to comment, Iswanto?
Yes. Thank you for the invitation to comment. So, just along the line what Amer just said, for a minor hepatectomy, peripheral segment resection, segment 2-3, I think the data are not very different in terms of robotic versus laparoscopic. Where the difference will be are in the difficult segment resection or major hepatectomy. Obviously, there's no randomized trial comparing the two, but there are large international studies, which we are actually part of it. We have 22,000 patients in there, which is head by the Singaporean group, Brian Goh. We actually compare right hepatectomy with extended right robot and laparoscopic, left and extended left robot versus laparoscopic, right posterior sector robot laparoscopic, right anterior sector robot laparoscopic. Those are like 5 different papers that basically shows superiority of robotic resection in operative time, conversion rate, and blood loss. Those 3 factors that actually favoring robotic for a difficult segment resection or major or extended major resection. But for minor peripheral wedges, I think the difference will be hard to prove. So, and this is the best data we have today. The multi-institutional 26 centers participate in, and this is what I can tell you. This is the best data we have. No randomized yet.
Shall we keep going, Amer? Is that okay?
Thank you. Yeah, one of the advantages of using the robot and liver resection is the use of ICG. Clear line of demarcation. Biliary structures are better visualized after IV injection of the ICG, and there is a difference between the primary tumors collecting the stain versus the liver mets, which usually form a rim around the tumor. Couple of videos I want to share with the audience. I apologize for the audio. they're pretty short. Let me see if I can, yeah. I'm removing the sound. So two main techniques that are utilized, so-called positive and negative staining. So here the inflow is clamped, and we can see the ischemic demarcation line initially. However, it's not that reliable, especially at the posterior superior segments. We can see here on the video that more challenging to see the demarcation line. However, with ICG staining, we can see the difference between the ischemic demarcation line and the ICG demarcation line. Especially, as I mentioned, superior segments where the access is not that easy. And another way of access of the demarcation line. All right. So basically, the first video it showed the ICG injection to the portal vein. Here, the ICG is given into the through the IV, and then the inflow is clamped. Again, ICG demarcation line is much clearer, especially in superior surface of the liver.
How does it always look so bloodless when somebody else is doing it?
Yeah. Major conclusions regarding robotic liver resections are presented on this slide. So basically, most of the perioperative and postoperative outcomes, oncological efficacy comparable to laparoscopic and open surgery, the better dissection of the hepatic hilum, hepatocaval plane could be done with robotic approach. Superior precision in biliary anastomosis and suturing, bleeding control with parenchymal transection, and easier utilization of new technologies. I think we're done with the liver part of my presentation. If anyone have any questions or any comments.
Amer, do you want to bring up any controversies that around?
No, I think that was a really good summary. I think Iswanto's data, that large set data is important. I think when we look at this data, blood loss is important, conversion is important. I think what we always want to look at is, really morbidity, length of stay. How are these things being changed? And obviously, we're all proponents of robotic and minimally invasive surgery, but we want to make sure that we have a tangible benefit at the end of the day, because robotics has been with us now for nearly 2 decades. So I think it's time that we show some beneficial patient impact. And to us, that's really one thing that we focused on here at Pittsburgh. But I think it's just harder to see it when it comes to livers in particular. I think you will have less bleeding, you'll have less conversions. But for a procedure in which the morbidity is relatively low to begin with, I think it's hard to prove a definitive benefit on patient outcomes, robot or lap, unless obviously this issue about posterior segments and the ability to sew a bile duct and so forth. So certain scenarios are I think beneficial, but overall, still remain skeptical about true benefits and outcome.
Dr. Hassan has a question.
So this is just from an outsider looking inside. So there's probably never going to be a randomized trial, or very unlikely. So with that in mind, how do you make the argument that robotics, and I don't disagree with it, but for somebody who's a skeptic, how would you make an argument that robotic surgery or robotic liver surgery is feasible and reasonable to do from a pure scientific standpoint? How would one make that argument?
And Amer, why don't we ask John Martini, who placed something in the chat? Is that okay with you? Who's a fan of robotic liver?
Yeah, of course.
Oh, hey guys, so I mean I kind of have to disagree with some of the comments, and I'm you know, I'm always a fan of large multi-center, multi-continent databases and stuff, but that's not necessarily always the best data because everybody's going through their learning curves at different points. And probably the two papers that I would quote as the best indicator for advantage of robotics would be if you look at the paper from Pittsburgh that was published in Annals. I mean, in that paper, I'm sure you guys are familiar with that, but there was a glaring difference in the percent of cases, major hepatectomies that were performed and completed laparoscopically or robotically than the laparoscopic arm. And you know, that's the way we found in our paper too. So like in our center where two surgeons do laparoscopy and two surgeons do robotics, there's a big difference in the percentage of major hepatectomies that are actually completed in a minimally invasive fashion. And that is, I'm telling you, that is what I personally have found to be a huge advantage of robotics. Now, it's not randomized data, and you could say there's selection bias and all that stuff, but it's high quality US centers. Both those papers should be quoted. And that's why I switched from laparoscopy, you know, because I never felt totally comfortable doing an anatomic right hepatectomy purely laparoscopically. And anybody can do like quote lap liver, and then halfway through they make an incision, they still count it as a laparoscopic case. I mean, that's the truth. So I would say that's a huge advantage, but I think is underappreciated. Probably it's not articulated well in the data though.
I agree.
Comment, John.
I agree. There's a bigger chance you're going to achieve a major hepatectomy robotically.
Yeah.
But it does depend on the experience of the surgeon, the skill set of the surgeon. There's a lot of laparoscopic, major hepatectomy surgeons out there. I just don't think there's a lot of laparoscopic Whipple surgeons out there. I think there's a bit of a difference between pancreas and liver.
Yeah, I agree.
And to be frank, Amer, just to finish this point, I think John's point is really important, that I think a lot of people do call a lap-assisted case a purely MIS case, which it really is not. So last comment, Rohan Jayaraja, which is Adnan Al-Saidi, please, and then let's hear the rest of the comment of the
No, this is a wonderful discussion. I think I want to echo what Amer said. I think we're comparing apples to oranges to bananas here. And in the end, there's a lot more equipment and instruments, including what the presenter mentioned in terms of CUSA, and that you can use a lot more stuff laparoscopically. That I do think that the data for laparoscopic major hepatectomies is not just strong, it's incredibly strong, and it's over a decade old. So to think that we can't do major hepatectomies purely laparoscopically is not correct. And there are thousands of cases who are pure lap and major hepatectomy, extended, rights, extended lefts. So I do think the robot has a place, but I do not believe in the sense that the way Amer described it, I think is spot on, in the sense that right now we don't have the data to say that robot is better than lap for major livers. We just don't. I think they're both equivalent at this point.
So with that controversial ending, let's move on, Dr. Kalabin.
Yeah. We're going to move on, and we're going to talk a little bit about robotic pancreatic surgery. Few historical aspects, as we mentioned, I think before. First distal pancreatectomy done in 2003. First robotic Whipple was done in 2001 by Giulianotti. And first case series were published in 2003. Only 8 cases were included in this case series. Morbidity rate was pretty high, 37.5%. One patient unfortunately died. Mean operative time was 8 hours. But still, with all these numbers in mind, it was concluded that it's pretty feasible and safe to do robotic Whipple. Unfortunately, however, complex pancreatic surgery procedures
Female
has slower transition to
Eve.
robotic approach.
mid-duct cholangiocarcinoma.
Oh,
John Martini, you're
Jaundice,
not muted.
diagnosed on ERCP and
Could you mute
MRCP.
everyone, please?
Probably.
Parentheses, performed
Dr.
February
Martini,
28, 2022.
maybe someone can.
End parentheses period.
Beverly, can you mute everyone, please?
Spyglass, which was performed on April.
John, you're not on mute.
Okay, thank you. Yeah, however, in recent decades, we can see the rapid development of robotic pancreatic surgery. Unfortunately, evidence-based guidelines are still lacking. The Miami International guidelines on invasive pancreatic resection in 2020 unfortunately stated that non-superiority of minimally invasive pancreatic surgery over an open approach due to insufficient data. However, recently, most of the programs are trying to incorporate robotic approaches in pancreatic surgery. This is just a brief description of the torque placement for robotic Whipple. This is from the Giulianotti paper. And you can see here two options for wide abdomen and narrow abdomen. Basically, Dr. Giulianotti moved arm 2 and 3 more to the left upper quadrant in a narrow abdomen for better exposure. I'm not going to go over details regarding the operative steps. We all know them in the sake of time. Outcomes of robotic Whipple. Again, a major case series, I think, were coming from the University of Pittsburgh as well. So the first case, the first story paper is a national cancer database that looked over robotic Whipple from 2010 to 2016, and these are the major points that were included. First of all, increase of robotic approach in general. Number of lymph nodes increased from 18 to 21. Postoperative mortality was decreased over the 6-year period from 6.7 to 8.1. Also decreased length of stay in most recent cases. No difference in survival and in regards to short-term oncological outcomes such as negative margins, readmission, conversion to open, were comparable. Another meta-analysis that was done in 2021 concluded that robotic Whipple had significantly longer operative time, but better blood loss, shorter lengths of stay, and decreased infection rate. Lymph node harvest, reoperation, readmission, and mortality was comparable to open surgery. This is a paper, larger single institution series published by Dr. Zureikat, which I found really interesting. So basically, they looked over 500 robotic Whipples from a single institution. Mean operative time was 415 minutes. Again, as was mentioned before, the time greatly reduced after the first 240 cases. So with the learning curve, the outcomes were a little bit better. Blood loss during the procedure was 333 milliliters, and blood transfusions were noted in 74 patients. 26 patients were converted to open. Lymph node harvest was 28 lymph nodes on average, and the negative margins were almost in 90% of cases. One of few papers that actually looked at the rate of postoperative complications. So the rate of the two most feared complications after Whipple, pancreatic fistula and delayed gastric emptying, were comparable to an open approach, 20%, 20.2% for pancreatic fistula, and 23.5% for delayed gastric emptying. 30-day mortality, only 9 patients, which was 0.8% and 90 days mortality in 15 patients, which was 3% from the total number of cases. Median length of stay was about 8 days. So the main conclusions from this a single institution series was with robotic approach, better operative time, conversion to open, better blood loss, and clinically relevant post-operative complication, and despite increasing complexity of cases. Another important findings that Dr. Zureikat found is actually with the learning curve, the group performed more complex cases with vascular reconstruction, if I'm not mistaken, which should be also mentioned. A few slides about robotic.
Can I make a comment? Just 2 comments here. If you can go back for a second, Alec.
Sure.
I don't want to belabor this, but we initially published a learning curve of about 80 cases. That's probably our true learning curve when it was Herb Zay, Jim Moser, and myself trying to learn from scratch, really, how to do robotic surgery. This 240 cases, surgeons left and surgeons entered into the program, and fellows started operating as well. So, when you look at operative time and reductions, you just have to know the nature of what type of program you're in. We want to make sure the fellows get a big role in an operation. So that's one thing. The second thing, I just want to make sure that I correct. You're right, the pancreatic fistula rate was 20%, but that included the biochemical leaks. Mm-hmm. So the B's and C's, the ones that matter to you and me and the patient, were at 11%. But I think a major component of the good outcomes here was also implementation of ERAS. We had implemented ERAS towards the latter part of the experience, and we felt that ERAS helped reduce length of stay as well. So just some minor comments there.
Mm-hmm. Yeah, thank you so much for this great input.
So I do want to spend a minute on Whipple, because I think that this is really, from the pancreas standpoint, Alec, I think this is kind of the holy grail, right? Even Grey's Anatomy talked about the Whipple. So Sharona Ross, let me ask you, one of the things that I feel is that something that David Welsh brought up in his chat was that, adhesions are good for us, right, in certain circumstances. And for me, the trouble I've got into is when there is a pancreatic leak after a robotic Whipple, there's not a bit of adhesion, so I end up putting a drain in the butt, because it's down in the pelvis or somewhere crazy. What are your thoughts, Sharona? Because in certain cases, adhesions are good.
Well, thank you for the question. So let's talk about adhesion in general. Many patients come with open operations previously and have a lot of adhesions coming into it. Talking about the robot is a great advantage to lyse adhesions easily with the robot. And I must say, when back in the day when we went, Rose McGee and myself, to learn from Zay how he did his robotic Whipples, he was doing a lot of laparoscopic approach for a large portion of the operation, and then dock the robot. Well, then we moved to watch John Martini, and he doesn't do anything laparoscopically, and did immediately dock the robot and start to lyse adhesions if there were any adhesions. So I think that, and then we converted all of our cases to do it strictly robotically. So the robot is a great tool for lysis of adhesions. Regarding difficulty with fistulas or reconstructions or putting a drain or not, I think that it really depends on the consistency of the pancreas, especially for the fistulas, and the robot allows you to do a really nice anastomosis that is more precise, at least in my hands, than any laparoscopic anastomosis. And really allows me to also do falciform ligament as a vascular pedicle, or mental flap as vascular pedicles, which, I don't know to what extent it really helps, but I do place a drain in all of them. So if I have adhesions, I would try to bring them down to a certain degree, take them down, and use a portion of omentum or falciform, or both, to buttress the anastomosis, and then leave a drain. So
Thank you, Shona. Amer, do you want to just comment briefly, and then we'll finish up with just a couple of comments, Alec, to finish your talk.
I think the one comment I would make is I would take minimal adhesions and a leak over an open abdomen and a leak. You know, we forget, because we're doing robotic Whipples through small extraction sites. If you have an open wound with a fistula, this patient is not going to get on adjuvant therapy. This patient is not, multiple readmissions. I think, you know, we always tell our fellows, you forget you forget what an open abdomen with a fistula looks like, and multiple debridements and dehiscences. So you don't see those with robotics. Yes, there's less adhesions, but you certainly don't see that major complication. I think that's a huge win for robotic Whipples.
So Alec, let's finish up with just, if you could summarize quickly on your distal experience.
Yeah, distal pancreatectomy. Basically, the outcomes, I would like to cite one meta-analysis which included more than 3,000 cases. The major advantages of the robotic distal pancreatectomy was rates of spleen preservation, which were higher compared to laparoscopic approach. Nowadays, actually, a minimal invasive distal pancreatectomy is a standard of care. So robotic group in this meta-analysis showed decreased length of stay, a lower conversion rate, and other outcomes in regards to blood loss, postoperative complication costs, lymph node harvest were about the same. This is just a picture, you know, showing us the feasibility of robotic gastroduodenostomy, pancreatic duodenostomy, and dissection of the hepatic hilum. And on the picture C, we can see the spleen preservation, the distal pancreatectomy. We can clearly see the hilum vessels, and the spleen is still in place, which is kind of pretty awesome. So my conclusions are robotic pancreatic surgery is safe and feasible. It's equivalent to open surgery in regards to short-term and long-term oncologic outcomes, although long-term oncological outcomes are not published to a great extent because it's a pretty new approach. Outcomes are comparable to open and laparoscopic approach in regards to morbidity and mortality. Future strategies. This is a slide I would like to point out, and a few important things that we can improve, and from the training standpoint as well. Operative planning is really important, and we probably talked about it already. It's the patient selection is really important, and where we're going and what are we doing. Another important point is training of staff, team emergency planning. Another important aspect we can focus on in future. My personal kind of desire is robotic surgery. The robotic HPB should be incorporated into the curricular and as many of training programs as possible, and more simulation labs for training in robotics should be implemented as well. I would like to thank you all for joining us today, and if you have any questions, please.
Amer, if you want to make a comment, then I'll wrap us up.
Yeah, I think Alec, great presentation, literature review. I'd maybe finish up with what we started with, which is, it's not about doing cases, it's about building programs. So, to do a robotic Whipple, so many things have to fall into place, which include starting to do your gallbladders robotically, even though there may be some pushback there in terms of administration or cost or OR time, doing your gastroduodenostomies that way, doing your livers that way. It is as you grow in terms of learning curve, your staff is going to grow, your fellows, your outcomes are going to improve. Certainly your circulating staff, your OR times are going to go down. The more familiar you and your staff become with the robot programmatically, the chances are you're going to be more successful in being able to do complex HPV procedures. It does take time. Be careful. Obviously, Having a second attending early on, I think is really important on many levels. One is getting out of trouble, case selection, but really this issue of mission creep. With these long procedures, it's good to bounce ideas off of someone, commiserate with someone, really share success with someone in terms of having a partner that's dedicated to programmatic growth. So again, not about cases, all about programs.
Thank you so much, Dr. Zureikat, and thank you everyone for joining us. Just one last comment. There was a reach out or a shout out for self-nominations for the SSAT committees. I would love everyone on this call to self-nominate, please. Dr. Imran Hassan is on the board and is really a great advocate. This is a great society. They meet in awesome locations and it's part of DDW. I just want to thank everyone for joining us today. And Dr. Zureikat, fantastic job moderating. Thank you. And Dr. Kalabin, as always, I'm a great admirer of yours. Thank you so much.
Thank you.
Thank you, Rohan.
Thank you.
Thank you so much.
Thank you.